Hello, class. This is Ofelia. So we're going to start the discussion for week 7. And I selected sexual sexual orgasmic disorder. According to the latest research, 3 out of 4 women say they cannot have an orgasm through vaginal penetration alone. Thus, I found that to be quite interesting. So according to the DSM-5, the diagnosis for the orgasm disorder is a delayed, infrequent or absent orgasm or markedly decreased intensity of orgasm after a normal sexual arousal phase in all or almost all occasions of the sexual activity. In addition to distress or interpersonal problems due to orgasm dysfunction. However, in search to find answer for what exactly is the orgasm disorder, I also found this article, which is quite interesting, and I would put the citations at the end of the video. There is an evolution of treatment of female sexual dysfunction that has been developed since the early 1990s, when the treatment for erectile dysfunction in 1998, they come out with what they could with sildenafil, or better known as a Viagra. So as we know, it has been many years since we have evolved somehow in treating sexual dysfunction. However, it was mainly focusing to males, not in females, which I found that to be quite interesting. So there is a society perception that it is important for men to preserve their sexual functioning and optimize their sexual performance. And this perception, coupled with perceptual innovations in male sexual medicine. And this has led into many treatments options for male's dysfunction. However, as we mentioned, is not the same thing for women. So most of the problems that men experience include including oral therapies for erectile dysfunction, multiple vehicles for hormonal replacement, shockwave therapy, and penile implants for refractory erectile dysfunction. Unfortunately, despite these many treatments, research, women with sexual complaints have been largely overlooked, as I mentioned before. However, within the past 10 to 11 years, there has been like an increase in the clinical and academic interest in the female sexual functioning. So things seems to be changing. However, the International Society for the Study of Women's Sexual Health was established in 2001 to serve as a multidisciplinary international community dedicated to advance this study in female sexuality. So it is a good thing, right, for us as a females. Moving forward with what is the behavior, what is the pattern of this sexual disorder, orgasmic sexual disorder. For women complaints of distress related to delay or absent orgasms, it is necessary to take the detailed medical and psychological history and to identify the possible offending medications. So there are some steps that needs to be taken before the diagnosis actually, the person is actually being diagnosed. There are some things that need to be taken into consideration, so whether there is any medical problems or psychological history that might be interfering in the sexual functionality of the individual. So understanding the problem is a lifelong and is completely interesting and important for the person who is diagnosing or treating the person to be aware of. There are some orgasms and delays or less intense. So it is important to point out that the sexual history of the individual, that way they can help to get kind of like the medical and psychological treatment that is going to take what direction it is taking it. Some of the behaviors that we can see or the complaints that we can see is that women might complain of low libido, and but also needs to identify whether it is a problem that is situational or it was acquired with many other circumstances. So it is important to be assessed. There is also an association with other forms of sexual dysfunctions. For example, we can see that they can have pain, poor arousal with, can often be found, can interfere in the difficult to reach the orgasm. However, the evolution show and believe that put the orgasmic dysfunction in the context of individual broader sexual function, thus physical exam, including a bulboscopy, should include an assessment of the clitoris. Someone may exhibit phimosis of the clitoris with or without any underlying etiology, such as sclerosis. So it's important to keep that in mind. Or it could be one of the psychological issues. Okay, according to psychology today, past experiences, behaviors, backgrounds, and mental well-being may contribute to the problems with orgasms, which include past sexual or emotional abuse, trauma, lack of knowledge about sexual stimulation and interaction, poor body image, guilt, embarrassment about sex, culture and religion beliefs about sex, which I believe that's a big one. It's a great factor that can impede or interfere in the, especially women's satisfaction. Stressors such as financial problem, loss of a loved one, and of course, mental health conditions such as anxiety or depression. See, does the therapy response based on gender of client? Yes, I did base it on woman. And one of the questions is if I would invite the partner to participate in therapy. I would definitely encourage the client as long as a partner to participate in therapy. However, if the person with the problem is reaching out for help, I would like to have at least 1 or 2 individual therapy sessions to get more information into what could be the possible causes of the problem. And from there, I will invite the partner, especially because the sexual interaction, if the problem is with, having the arousal or the orgasm with the partner needs to be aware so they are in the same page and they can also collaborate with the treatment. Moving forward, I also can find an article that states that explains clearly what could be one of the treatments to work in, the people who experience orgasm dysfunction. So according to this article, the medical treatment of orgasm problem is challenging, although there has been reports of successful treatments in which mindfulness is included, yoga, the use of sex toys, and sex therapy. I'm pretty sure that also maybe CBT or cognitive behavior therapy can play a good role, especially if the stressors are due to anxiety, mental health conditions such as anxiety or depression, or any cultural or religious belief, which also needs to be challenged. Some clinicians have experimented with the off-level use of testosterone, dopamine agonist, and johembines hydrochloride with encouraging results, although there are no clinical trials to currently support their usage. Again, one of the reference I use is by Krukonsky and his team, which is a study done in 2018. The article is a practical guide to female sexual dysfunction. And I also use the Handbook of Clinical Sexual and Mental Health Professional, chapter 4. And this is page 155. Hope this was helpful, and you're more than welcome to leave any comments here and anything that could improve this video. Of course, it would be welcome. Thank you for watching.